So it's early 2026. We have, self-driving taxis in all the major cities now. We've got AI that can literally write a passing bar exam. And we're actively planning manned missions to Mars.
We really are living in the future, yeah.
Right. We are living in the future. And yet, if you walk into a pharmacy pretty much anywhere in the United States today with a simple prescription for basic ADHD medication, whether that's Adderall, Ritalin, Vivance, there is a very, very high probability that you are going to be turned away empty-handed.
It really is the great paradox of our time. We've completely mastered the complex stuff, but the basic supply chain for essential medicine, that's just where we are utterly failing.
And we aren't just failing a little bit. I mean, we are 4 years into this thing. I'm your host, a healthcare policy analyst, and today I'm joined by our resident pharmaceutical supply chain expert to really unpack this.
Thanks for having me. I'm excited to get into this.
Me too, because I was looking at the timeline right before we started recording, and the headlines about the quote-unquote Adderall shortage really started popping up in late 2022.
Yep, late 2022.
And back then, I remember thinking, okay, supply chain hiccup. It's kind of like the toilet paper thing during the pandemic, right? Just give it a month, it'll smooth out.
Right, the system will correct itself. That's what everyone thought.
Exactly. But here we are. It is 2026, and millions of Americans are still, calling 10 pharmacies a day, rationing their pills, or just flat out going without.
And that is exactly why we're doing this deep dive today. Because if you just read the daily headlines or even look at the official PR statements from the manufacturers, you might actually think this is just a simple case of, well, demand is up and supply is down.
Just basic economics.
Right. But when you look at the stack of reports we've gathered for today, specifically that latest comprehensive analysis on the crisis from January 2026, you realize this isn't just a shortage. It is a complete systemic failure. It's a collision.
Okay, a collision. A collision between what exactly? Because usually, I mean, if demand is up, someone out there figures out how to make a ton of money by supplying it. That is just basic capitalism. So why hasn't the free market fixed this?
Well, that's the very first assumption we need to break today. The market hasn't fixed it because it basically isn't allowed to. And in some weird ways, it's actually disincentivized to.
Disincentivized?
Yeah. We're looking at a massive collision between a regulatory system that was designed back in the 1970s to fight drug abuse and a modern healthcare reality where mental health diagnosis is just skyrocketing.
Okay.
And then you throw in some truly baffling economic incentives that essentially punish pharmacies and companies for making and selling these drugs, and you have a perfect storm.
Wow. Okay, let's unpack this perfect storm, because going through our sources, it becomes pretty clear this isn't just about frustrated patients anymore. It's becoming a genuine public health emergency.
Absolutely. The stakes have entirely changed.
Right.
We aren't just talking about, people struggling to focus at their desk jobs. We're talking about a massive rise in counterfeit pills, dangerous black markets, and a regulatory framework that seems to be actively fighting against the exact patients it's supposed to protect.
So let's start at the root of the issue. Or at least what the government claims is the root, the DEA.
Right. The favorite scapegoat.
Exactly. Whenever this topic comes up, people point their fingers at the DEA and their quotas. But how does that actually work on a practical level? Does the DEA literally just sit in a room and decide how many pills get made?
Effectively, yes, they do.
Yeah.
This is the concept of APQs, which stands for aggregate production quotas.
Okay.
Because stimulants like amphetamine and methylphenidate are scheduled to controlled substances, meaning the government classifies them as having a high potential for abuse. The DEA sets a hard numerical cap on the total amount of raw material that can be legally produced in the U.S. each year.
So it's a ceiling, like a hard stop.
It is a hard ceiling, and here is the fatal flaw in that design. How do you think they decide where to place that ceiling?
I mean, I would hope they look at doctors' prescriptions or current patient needs.
You would hope. But they look primarily at historical sales data, and then they project demand based on the past. Essentially, they're driving a car at 100 miles an hour, but they are looking exclusively in the rearview mirror.
That seems incredibly risky given how fast healthcare trends change.
It is. It creates what policy analysts call a regulatory lag. The DEA looks at data from last year to decide what you and I might need next year. But demand for ADHD medication isn't a flat line. It is a rocket ship.
Yeah, I saw this crazy stat in our research notes. Stimulant prescriptions increased by 60% between 2012 and 2023. 60%. That is massive, massive growth.
It's astronomical.
Yeah.
And the curve got even steeper during the pandemic, which is where we have to talk about the telehealth factor.
Right, the Ryan-Haight Act waivers. I keep seeing this pop up in the source material.
Exactly.
Yeah.
So for those who don't know, the Ryan-Haight Act is a federal law that basically says you need an in-person medical evaluation to get a prescription for a controlled substance.
You have to physically sit in the doctor's office.
Right. But during COVID, the government obviously wanted people to stay home, so they waived that requirement. Suddenly, you could see a psychiatrist on Zoom and get diagnosed.
Which, to be fair, was a total game changer for access, especially for, women and adults who had gone undiagnosed for years simply because they couldn't take time off work or maybe they didn't have a specialist within 50 miles of their house.
100%. It completely democratized access. We saw a huge surge in adult diagnoses, particularly among women, who had historically been completely overlooked by the psychiatric community when it came to ADHD.
Right.
But here's the friction point. The regulatory quota system, the DEA's APQs, wasn't built for a sudden, massive influx of new patients. It was built for a slow, steady, predictable state. So actual demand went vertical, but the ceiling stayed relatively flat because the DEA was still looking at old historical data.
But hold on, let me push back on that for a second because I'm looking at the timeline here. And in October 2025, so just a few months ago, the DEA did actually raise the quotas.
It did.
Yeah, they bumped deamphetamine up by 25% and Vyvanse by roughly 20%. So if they finally raised the ceiling, shouldn't that have fixed it? Why are the pharmacy shelves still empty right now?
You would think it would fix it, and honestly, that is the most frustrating part for the patients. They read a headline that says quotas are up, and they expect the problem to be instantly solved. But a quota is just a permission slip.
A permission slip? What do you mean?
Just because the DEA hands a manufacturer a piece of paper that says, okay, you are allowed to make 25% more this year, doesn't mean the manufacturer physically can.
Why not? If they have the green light, what's stopping them?
The physical ingredients. To actually make an Adderall pill, you need APIs. That stands for active pharmaceutical ingredients. These are the raw baseline chemical compounds, and there is a massive bottleneck there. Even with a higher legal quota, manufacturers are struggling to actually procure the raw materials to make the drugs.
So the government finally says go, but the factories are basically saying, hey, we don't have any gas.
Precisely. And that leads us straight into the second part of this absolute disaster, which is the sheer fragility of the manufacturing side.
This is the part of the deep dive that really scares me, because the system just seems so brittle. Our sources mention that this whole multi-year crisis really kicked off because of one single company back in late 2022.
Teva Pharmaceuticals.
Right, Teva.
They are the largest supplier of generic Adderall in the U.S. And in late 2022, they experienced a manufacturing delay. Just one company had a delay. But because the entire supply chain system has practically zero redundancy, zero slack built into it when Teva stumbled, the whole tower collapsed.
And this is where my brain just gets stuck. Because when Teva couldn't deliver, why couldn't the other companies just step up? Isn't that how the free market is supposed to work? Like, if one burger joint closes down, the one across the street just sells more burgers. Why didn't Pfizer or Sandoz or whoever just ramp up their production lines?
Well, in a normal, unregulated market, yes, that's exactly what happens. But remember, this is a highly controlled market.
Hey.
Other companies couldn't just step in because, one, they were strictly constrained by their own DEA quotas, and two, they physically didn't have the capacity. You can't just spin up a controlled substance factory overnight.
Okay, that makes sense.
But there's a much darker economic reason why the generic supply is so incredibly tight. It's a practice called pay for delay.
Oh, man. I read about this in the notes, and I literally had to reread it because it sounds like it should be highly illegal. Let's break this down for the listener.
It is an antitrust nightmare. Okay, so imagine you have a big brand name drug manufacturer. Their exclusive patent on a drug is about to expire, which means much cheaper generic versions are about to flood the market and absolutely kill their profit margin.
Right, because generics are way cheaper, so everyone's insurance just forces them to switch.
Exactly. So, what does a brand name company do to stop this? They go to the generic manufacturers getting ready to launch, and they say, hey, we will literally pay you millions of dollars to not release your generic version for another year or two.
They pay them to just sit on their hands?
They pay them to delay. It usually happens as a settlement to a patent lawsuit. And the direct result of this is that the supply of affordable generic medication is artificially constrained. We have legal actions and settlements detailed in the source material confirming this happens. It purposefully keeps market prices high and overall supply low.
So they are literally paying their rivals to prevent competition. That
Yes.
is
It
infuriating.
really is. And because there are fewer generic options actually making it to the market, there is less redundancy overall. If one of the few active factories goes down, there just isn't a robust field of competitors ready to fill the gap.
Okay, so that completely explains the broken manufacturing side. Now, I want to pivot to the pharmacy side because I have heard this from so many friends. They go into the pharmacy and the pharmacist acts like they don't even want to fill the script, like they're actively annoyed by the customer. Is that just, a healthcare burnout?
It's not just burnout, though that's real. It is bad math. It is a structural economic problem called under-reimbursement.
Under reimbursement. How does a retail store actually lose money by selling a product?
It happens because of how the insurance middlemen, the pharmacy benefit managers, or PBMs, set the prices. Often, the reimbursement rate that the PBM sets for a generic stimulant is actually lower than what it costs the pharmacy to buy that pill from the wholesaler.
Wait, let me get this totally straight. So if the local pharmacy buys a bottle of generic pills for $10, the insurance company might only pay them $8 for it.
Exactly. So every single time they fill a script for your generic Adderall, that pharmacy is literally paying $2 out of their own pocket just to help you.
So their entire business model for this drug is literally lose money on every sale.
Right. So if you're a pharmacy manager, logically, what do? Even big chains like CVS or Walgreens, they keep their inventory incredibly lean. They don't overstock. They might even intentionally limit how much they order from the wholesaler just to minimize those guaranteed financial losses.
That is just mind-blowing. So we have a government quota artificially capping production. We have manufacturers literally paying each other to delay generics from existing. And we have pharmacies losing money if they actually manage to sell the drug to you.
Yep. And caught right in the absolute center of this vice grip is the patient.
Let's talk about the patient, because the human cost here is just staggering. The stats from late 2023 showed that 71.5% of adults reported difficulty filling their prescriptions. That is nearly three-quarters of all patients.
Think about what that means practically. If you have ADHD, consistency is the entire key to treatment. But suddenly you are forced to ration. You skip the weekends. You break a pill in half. Doctors sometimes call these drug holidays. But that makes it sound so relaxing. These aren't holidays. They're forced periods of withdrawal, intense brain fog, and severe emotional instability.
I was reading through accounts in sources of people losing their jobs because their productivity just tanked, students failing out of college classes, and just the massive emotional toll, the chronic anxiety of simply not knowing if you're going to be able to function next month.
Because it becomes a full-time job just finding the meds, you're calling 20 different pharmacies, you're driving 3 towns over just to get a partial fill. And remember, we are talking about a neurological condition where executive function, which is planning, organizing, initiating tasks like making phone calls, is exactly what is impaired.
Yeah, that's such a great point.
We are asking people with profound executive dysfunction to flawlessly navigate the most complex, frustrating, bureaucratic maze in all of modern healthcare.
It's a very cruel irony. But there is actually something even scarier in our notes than just the massive inconvenience and the job losses. And this is the part of the deep dive where I think we really have to issue a serious warning to anyone listening. The counterfeit threat.
Yeah, this is by far the most urgent point we have to make today. The sources cite a CDC advisory from June 2024. And reading this just stopped me dead in my tracks.
It should stop everyone in their tracks. Walk us through it.
The shortage has lasted so long and people are so desperate that it has created an incredibly robust, highly dangerous black market. Patients who are desperate to keep their jobs, or people who maybe can't get a formal diagnosis but used to just buy a few pills from a college roommate, they're turning to the internet or to, a guy they know.
And what are they actually getting? Because they think they are buying genuine Adderall.
They absolutely think they are. The illicit pills look perfect. They have the right orange color, the right shape, the exact right manufacturer stamp on them. But the CDC found that 7 out of 10 counterfeit pills seized by law enforcement contained a lethal dose of fentanyl.
7 out of 10. That is practically a death sentence.
Let's let that sink in. Taking a pill you bought online isn't like buying a fake designer handbag where the worst that happens is the stitching falls apart. This is playing Russian roulette with a pistol that has bullets in almost every single chamber.
Wow.
The medication shortage has inadvertently created a massive market for deadly fakes. We're taking a standard, highly treatable condition like ADHD and turning it into an active overdose risk.
That really puts the whole regulatory lag thing in a completely new, terrifying light, because the DEA is doing all this to prevent drug abuse, right? But by restricting the safe legal supply so severely, are they actually pushing normal people directly toward the most dangerous possible supply?
That is the central question of this whole crisis. When legitimate medical access is cut off, human demand doesn't just magically disappear. It displaces. And in this case, it displaces to the most dangerous, unregulated alternatives imaginable.
And we should probably mention this crisis isn't hitting everyone equally either.
Oh, definitely not.
Uh,
As always with healthcare, it hits the marginalized populations the hardest. If you live out in a rural area, you might only have one pharmacy within 40 miles. If that specific pharmacy closes, and we know major chains have closed hundreds of stores recently, you are totally stranded.
right.
And if you're on Medicaid or you have really cheap insurance that only covers the generics, you can't just casually tell the pharmacist, oh, well, just switch me to the expensive brand name Vivance if that's the only thing you have in stock. You literally can't afford it.
So we have a crisis that is regulatory, it's economic, and it is a massive humanitarian issue. But it is early 2026. What is the path out of this? Because we can't just sit here and admire the problem. What are the actual solutions proposed in the reports to stabilize this chain by the end of the year?
Well, the roadmap is clearly laid out in the source material, but it really requires serious political will. The very first fix has to happen at the DEA level.
Right. Fixing the quotas.
They need to move away from this annual guesswork and move toward real-time adjustment. The reports call for, quote, flexibility. Instead of looking at sales from 2024 to set hard limits for 2026, they need to ingest real-time, anonymized prescription data. If doctor prescriptions unexpectedly spike in January, the production quota should automatically adjust upward in February, not the following year.
That seems like an absolute no-brainer with the kind of software and technology we have today. Why hasn't that happened yet?
Mostly bureaucratic inertia. It requires a fundamental cultural shift in how the DEA operates. They have to move from a rigid policing mindset to a dynamic public health mindset.
That's a big ship to turn.
It is. Secondly, we absolutely have to address the telehealth uncertainty. We've basically been living on temporary, extended waivers for years now. The government needs to finalize permanent, clear rules so that legitimate telehealth providers can operate and patients can get care without this constant dark cloud of regulatory uncertainty hanging over them.
Make the rules permanent. Okay. And what about the manufacturing side? How do we stop the pay-for-delay mafia tactics and the massive lack of raw materials?
Domestic investment is the key there. We rely way too heavily on fragile global supply chains for those APIs, the raw ingredients. There's a huge push right now to start treating pharmaceutical manufacturing as a matter of critical national security. We need to heavily incentivize making those base chemical ingredients right here in the U.S. so we aren't completely at the mercy of a shipping delay halfway around the world.
And what about the antitrust stuff, the companies paying each other?
That requires the FTC, the Federal Trade Commission, to really step up. Cracking down hard on these pay-for-delay legal settlements would allow generics to enter the market much sooner. And as we know, more competition usually means more supply, better redundancy, and lower prices for the patient.
Okay. And there was one more thing in the report, transparency.
Yeah, that's the final major piece of the puzzle. Right now, drug manufacturers treat their supply chain data like it's classified state secrets. If Teva is having a factory problem on Tuesday, nobody else in the industry knows about it until the pills physically stop arriving at the local pharmacy a month later.
Wow.
We need a federally mandated system where manufacturers are required to disclose supply issues and API shortages before the drought actually hits, so other parts of this system have time to adjust.
Basically predicting the shortage rather than just reporting on it after everyone is already suffering.
Exactly. We need an early warning system for essential medicines.
So, as we wrap this deep dive up, I really want to go back to something you said right at the beginning of our chat. You called this whole situation a collision.
Yeah, it really is a collision of core philosophies. On one side, you have the DEA, whose entire governmental mandate is control and restriction. Their metric of success is preventing diversion and stopping abuse. But on the other side, you have the pharmaceutical industry, whose mandate is profit. Their metric of success is strictly the bottom line.
And the patient.
The patient is just the collateral damage. The patient is trapped squarely in the middle of a policing system designed to treat them as a potential drug addict rather than a person needing medical care, and an economic system that views their daily medication as a low-margin commodity that isn't worth keeping in stock.
This is a very sobering reality to look at.
It is, but I will say, the DEA quota increases we saw in late 2025 were a start. The widespread awareness is finally there. And the solution isn't scientific, right? We know exactly how to physically make these drugs. The chemistry is 80 years old. The solution is entirely bureaucratic and economic.
Right. True stability means society recognizing that this infrastructure, the basic ability to get normal people the medicine they need to function at work and school, is critical. It's not optional.
And there's one last thought I really want to leave you with today. We have spent the last decade rightfully horrified by the opioid crisis, which was definitively a crisis of overprescription and massive oversupply. Too many pills flooding the streets.
We were absolutely drowning in them.
But what we are living through right now is the exact inverse. It's a stimulant crisis of extreme undersupply. And we have to ask ourselves as a society, if our regulatory framework is so incredibly rigid that it forces law-abiding, everyday patients toward the black market, straight toward fentanyl, has the regulation itself become the actual hazard? Has the shield effectively become the sword?
That is a massive question. And it actually brings up something else I've been mulling over, building off all these reports. We're talking so much about the supply side failing to meet the demand, but look at why that demand is skyrocketing in the first place.
Right, the 60% increase.
Exactly. We have built a modern knowledge work economy that demands a level of sustained, unbroken executive function and hyperfocus that human brains fundamentally did not evolve to maintain for 8 to 10 hours a day. So we have to medicalize our own attention spans just to survive capitalism. And then our institutions structurally deny us the exact medication they've made necessary. It's almost like we're punishing people for trying to adapt to the system we force them into.
That's an incredibly profound point to end on. We're demanding peak performance while withholding the tools.
Definitely something I think every listener needs to sit with and explore on their own. If you are out there and you're struggling to get your meds this month, just know that you aren't crazy, you aren't alone, and it is definitely not in your head. It is deeply embedded in the system.
Stay safe out there, everyone.
Thanks for listening to this deep dive. We'll catch you next time.